everyone, and welcome to our first of two videos on the joints. Now, in this first video, we're going to be focused primarily on the different types of joints we have and how they're built and how much movability they have. In the second video, we're going to be looking more in depth at a specific class of joints and talking about more clinical aspect of our articulations. So focusing on disorders that we might see in the hip, knee, and shoulder, and looking at how they're built a little bit more in detail. So that's what we'll be looking at in the next video. So let's get started. Now, in terms of joints, we can classify them based off of either how they're built or how they move. And I'll be presenting them in the category that we call structural, which is how they actually are built. Now, we can build a joint using three different types of material. If it's a fibrous joint, it's going to be built using dense collagen fibers. If it's cartilaginous, we'll be using some type of cartilage. And if we tend to see ligaments involved, it's called a synovial joint. Now, we will also be tying in the functional classification of these joints. And when we talk about functional classification, that means how much movement does that particular joint afford? Does it give us a lot of movement, like in my wrist or my fingers? That's called a diarthrosis. Does it give me no movement at all? Like I see here in my skull, all these bones that we learned about in lab, they are fused together. There's no movement there. So that would be called synarthrotic, or it's a synarthrosis. And lastly, we have amphiarthrotic joints. These are joints that provide a small amount of movement. So what I want you to do is take both your hands like this, palms together, and press on them, and then try to move your palms forward and backward. That's about the amount of movement an amphiarthrotic joint will give you. So we have none, very little, or a whole wide range of motion. So we're going to start today talking about our fibrous joints. Once again, these typically are held together with dense irregular connective tissue, a lot of collagen involved there, and depending on which of the types we're looking at, there will be either no movement or very little movement. So once again, we're not looking at motions like this yet. That's actually a whole separate class. Now you'll notice as we move through these three classes, the first two are always going to say that there's no synovial cavity. That's because the synovial cavity, which we'll look at the end of the lecture, is a very specific structure that is unique to synovial joints. So we won't be seeing these in fibrous or cartilaginous joints. Now, the three types of fibrous joints we're going to look at today are going to be sutures, which we've already investigated in lab. We'll be looking at syndesmoses, and we'll be looking at gomphoses. So let's kind of take things easy, and we'll start with our sutures first. Now remember, sutures are found between the bones of the skull. Okay, they're all those little sort of zigzags that you could see that helped us delineate where one bone started and another bone ended. It was a really good landmark for that. Now in lab, we did not learn what every squiggle on the skull is. We were looking at what are the connection points for the major cranial bones, not really the facial bones. Now, remember, we have 5 different types of sutures, and we'll be able to take a look at them in just a second. We had the coronal, the sagittal, the lambdoidal, the squamosal, and then we had the metopic suture. Remember, the metopic suture, I actually don't have an image for this one, but it's going to be the little suture that runs between the bones, the frontal bones here, in young infants before they fuse together. So that's a fetal skull only suture. And as we've talked about, because the cranium, its job is to protect the brain, we do not want any shifting. Even that amphiarthrotic movement could cause problems or damage to the underlying structures. So we really don't want the skull to move once it's fused. However, in young infants and children, these sutures don't typically completely fuse, right? We have those fontanelles that sit in between the bones, and this is going to allow for the rapid expansion of the brain so that they can learn all of the skills and milestones that they need as they are developing during that time period. So once again, here are our sutures. We can see our squamosal suture here, the one just above your ear when you go like that. The lambdoidal, remember, is going to be the one that sits at the back of the skull. And remember, the easiest way to remember that one is it looks like the Greek letter lambda. And then we have our sagittal suture that's going to run down the middle of our skull here. So you have sagittal here, and then you have your coronal that's going to separate the frontal from your parietal bones. Now the second type of fibrous joint we have is a syndesmosis. And a syndesmosis is going to be sort of characterized by a, typically, you will see a sheet of tissue between two bones. It's not always there, but we will typically see two bones put together. That's what a joint is. And a lot of times there'll be this membrane of tissue that we call the interosseous membrane. So that is what we see when we look between the tibia and the fibula. You have it between the radius and your ulna. And one example of a syndesmosis is this guy right here. Now, one thing about the examples I'm going to give you throughout this presentation, these are not the end-all be-all of every possible type of syndesmosis or synchondrosis and things like that. These are simply just some examples that I feel are easy to remember, and your textbook may go into more detail or give you other examples. The only ones that you're required to know are the ones that are here. Now this guy is called the anterior, because it's at the front, tibiofibular ligament, or at the anterior tibiofibular joint. This is basically where your ankle is, and it gives you a little bit of movement, okay? When we're walking, okay, the motion where your foot is going to kind of do this is my foot, this is my shin, that articulation happens down here, right, with the talus and the tibia. But as we're walking, we're putting weight on the leg, and we're moving our ankles in different ways. And we want this joint to have just a little bit of give to it, enough that it can account for different changes in force and the plane that we're walking on. Not so much that both of those bones can do this. That would be very detrimental. And we don't want it so that the two bones never ever move. It would make walking very difficult. So by giving the tibia and fibula the ability to kind of do slight movements going along with changes of what's going on with our gait, it helps us walk better. So that's what the syndesmosis does. So the syndesmosis has this little pad of tissue between it, typically, we will see associated with that interosseous membrane. Now the last fibrous joint we have is a gomphosis. And gomphoses are synarthrotic. They do not move. These are the connections of your teeth in the alveolar sockets. Now, here's the thing about gomphoses. I often am asked, well, if it's a synarthrotic joint, how do braces work, right? Because braces are where you put metal apparatus and a high amount of pressure on your teeth over a long period of time to change their position. So we can't just grab a tooth and move it. If you can, that's a sign of advanced periodontal disease. That's not good. typically our teeth are not going to give any motion at all. However, when we put braces on, we apply that torque and that tension on those wires, it slowly changes and pulls on those teeth, okay, putting them into new positions. If you don't wear your retainers, they will just go right back to their original place. So our teeth are synarthrotic. They should not move, right? We don't want our teeth to kind of have any sort of movement to it when we're chewing. That could be a big problem. But we do have the ability, with a high amount of tension, to change the position of teeth, okay? So they don't do that on their own. It requires outside force. Okay, that's it for fibrous joints. Notice none of them were diarthrotic. They all were either synarthrotic or had just a little bit of movement, and they were collagen fibers, typically, that were kind of keeping things together. Cartilaginous joints are pretty easy because they're made of cartilage, and we're actually only going to be using two different types of cartilage. We'll either use hyaline or we're going to use fibrocartilage. Now, one of the issues with cartilaginous joints is one of the types. We call it a synchondrosis. It sounds very similar to a syndesmosis. So before we go through what a synchondrosis is, let's just try to remember, how can we not get these guys confused? Let's look at that root word here. Chondro. Remember the root word chondro. This means cartilage. So if on a test question or a homework question you're asked, hey, what is a synchondrosis made of? The answer should be some sort of cartilage. If you start to choose an answer that does not have the word cartilage in it, you need to stop and think, right? Look at the word. It gives you the hint. Chondro means cartilage. Now, the synchondrosis, these particular joints are made of hyaline cartilage. Now, they are synarthrotic. So once again, remember, synarthrotic means there's no movement. So let's look at some of the examples and we can kind of go through why we wouldn't want any movement in this joint. And for those of you that are still trying to have a hard time of like, well, joints, we think of joints, wrists, fingers, they should move. Not all joints do. Okay, remember, a joint is just a connection between two bones. So the first one I have here is the epiphyseal plate, and that's kind of what we're looking at here on this diagram. When we talked about bone development, remember the epiphyseal plate was a pad of hyaline cartilage left over from endochondral ossification that allowed the bone to grow in length as we went through adolescence. Now, these epiphyses, remember the ends of the long bone, okay, they're connected to the rest of the bone through that epiphyseal plate. If we had even amphiarthrotic movement between these sections here, the bones, just from basic movement, could get out of alignment, and that would cause the bone to grow in the wrong direction. Let alone if they were diarthrotic, imagine the malformation you could have of your long bones. So we want the epiphyseal plate, synchondrosis, to stay in place, no movement, because it's going to help guide where that bone will lengthen. Now the other example I have for you is the articulation between your manubrium, which remember this is the top portion of our sternum, to our first rib, which you really typically can't feel because it sits here underneath your collarbone. But your first rib, if you guys remember from lab, it's this really, really C-shaped, teeny, teeny, tiny rib bone. And it sits right about here. Now coming through here, we have nerves and we have blood vessels. And we really don't want a lot of shifting to happen in this general area, because if there's a shift there, once again, even an amphiarthrotic shift, that little tiny movement, that can lead to pinching off an artery, pinching off a vein, compressing a nerve, which could lead to a lot of different problems. So where that first rib meets the manubrium, it does not move, because we don't want to impinge any of the underlying structures that are running either to the arm or up to the neck. Now, the last type of cartilaginous joint we have is a symphysis. Now, the type of cartilage we're using here is fibrocartilage. Remember, fibrocartilage is really, really strong. Its job is to connect and join structures together. Hyaline cartilage, remember, not as strong. This particular type of joint is going to be amphiarthrotic. It will give us that small amount of movement, not diarthrotic, not synarthrotic, but just a tiny little bit of movement. So I have 3 different examples for you. The first one I have is probably the easiest one to remember because it has the name symphysis in it. So you might see it as the symphysis pubis or the pubic symphysis. This is going to be the pad of fibrocartilage where your pubis of either os coxa is going to meet up. So this is at the front of your pelvis. And we'll talk a little bit more about its importance clinically in just a second. So this is a little pad of fibrocartilage. We want to have some amphiarthrotic movement here, once again, for walking. It gives our pelvis the ability to kind of produce that walking movement. We don't want them to slip in and out. We don't want them to stay stagnant because walking is a very active motion, but we do need to have some ability to accommodate as we're walking. The other example we have are the intervertebral discs, and you guys should remember these from your first lab unit as locations for fibrocartilage. So the intervertebral discs are pads of fibrocartilage that are going to sit in between each body of your vertebrae. They provide cushion and connection between those vertebrae. Once again, your spine is quite mobile, and we want to make sure that we are able to provide movement of the spine, but not so much that the vertebrae themselves are slipping in and out of position too much, because remember, running through that vertebral column is your spinal cord. Now, the last one I have here is the sternal angle, where the manubrium meets the body of the sternum. Remember, you can kind of feel that if you find your jugular notch go down, you might feel a little ridge or an indentation. That's the sternal angle. This does provide a small amount of movement because of breathing. When we take a deep breath in, our rib cage is going to expand. And so this allows for that small amount of movement of your sternum so that you can take in that deeper breath. Once again, we're not doing this with our sternum. It would provide inefficient protection for what lies underneath it, but it does have a small amount of give so that as we are taking a breath, we are able to take a deeper one. Now, here's some clinical connection to the pubic symphysis. Normally, the width of the connection here between the 2 pubis bones is about 3 to 5 millimeters. It's quite small. During pregnancy, as we'll talk about later on in the course, there's a lot of hormones that are released. One of them is called relaxin. So relaxin, as the name kind of indicates, is going to relax a lot of different aspects of your body to help prepare things like the pelvis for birth. It focuses a lot on the pelvis at the SI joint and here at the pubic symphysis. So a lot of women who are pregnant, myself included, tend to have pain at their SI joint, feeling like their hips might be out of place because the body is sort of preparing to widen that pelvis so that the fetus can make its way out through the birth canal. During pregnancy, some women may develop what's called pubic symphysis dysfunction, which is where the gap gets almost 3 times as big as it originally was, up to 9 millimeters, and it can be quite painful because your pelvis is quite out of joint. This widening, not the dysfunction, but the widening is typically where you get that sort of waddly gait, because now your hips have widened and it's changed how your legs sit and now how your legs move. So you kind of get that different gait. Some women can even get diastasis here, which means separation. So it can be severe, but most women just have a widening here, maybe some minor ache and pain, all to prepare that pelvic inlet to be wide enough for the shoulders and the head of the fetus during delivery. All right, so the last sort of joint we're going to talk about right now is the class of synovial joints. Now, synovial joints are what you think of when you think of a joint. If I had you write down a joint at the very beginning of this lecture, a lot of you probably would have written down maybe the jaw, the elbow, the wrist, the knee, the hip. These are all types of synovial joints. And as we'll see in the next video, they are built a little differently, provide different movements, but overall, a lot of them can have this basic structure, and we are going to, over the next few slides, look at some of, like, you can think of the add-ons we can put in to build these synovial joints. Now, because it is a synovial joint, that means it has a synovial cavity. Now, the synovial cavity is the space between the two bones. I'm going to draw this very poorly, and then we'll take a look at a better drawing on the next slide. So we can just say these are 2 finger bones, and we're going to connect them with our capsule. So what we have first is the articular capsule. This is the part that's going to enclose the synovial cavity, which is here. So here's our cavity. This is the capsule. Now the capsule itself will have an inner lining that will be the membrane here. And then we also have the outer fibrous membrane, which is going to be sort of this outer part here. The fibrous membrane is basically, this can be ligaments. So you think of the knee, these would be like the MCL and the LCL. The synovial membrane, if you recall back from our discussion of tissues, this is going to be that layer of synoviocytes who are going to produce synovial fluid. And that synovial fluid is going to nourish and fill that synovial cavity. It's going to lubricate the joint so we have good movement. Okay, when that fluid is not warm, sort of cool, it makes the joint a little stiff. And then as you start moving the joint or apply a heating compress, it warms the fluid up and it increases the mobility. It is a fluid, and based off of physics, fluids really are very good at absorbing shock, which is very important when you're looking at joints like the knee or the hip when we talk about walking. And of course, they act as nutrient and gas exchange. Now, one other structure that we can see in a synovial joint is an articular fat pad. And this is basically just some fat that you'll see in the synovial membrane. If you recall back to the chapter on membranes and you looked at that structure, you could see the synoviocytes lining the synovial cavity, and kind of embedded in that membrane were some little globules of fat. One of the most obvious fat pads is the infrapatellar fat pad. So infra, below, patellar, patella, and it's a fat pad. So there's a little bit of fat here inside the synovial cavity that helps with cushioning of the patella. So let's just review our synovial joint structure. Once again, we have the articular capsule, which is made of that outer fibrous membrane, basically ligaments. And then we have the inner synovial membrane. Recall from our discussion of the structure of a long bone, the ends of all long bones are covered with articular cartilage. That's hyaline cartilage left over from the process of endochondral ossification. And what it does is it provides a smooth surface so the bones won't grind over each other. If that articular cartilage wears away or becomes inflamed, that's where you get osteoarthritis. And osteoarthritis can come on due to natural degeneration of the cartilage as you get older, or it can come on from injuries. So I have osteoarthritis in I think both my shoulders and at least one of my knees from the different injuries that I've had. It's different from rheumatoid arthritis, which we'll talk about, or we can talk about more when we get to the immune system. Okay, let us move on and talk about some structures we can see that are associated with a synovial joint. The first one are going to be ligaments. So as we look at specialized joints, we are going to be learning some ligaments. Now, ligaments can be found either on the outside of the joint or on the inside. And so I'm just going to use the knee here as an example because it's probably one of the most famous joints. And most people have heard of these particular ligaments. So when we talk about extra versus intracapsular, extra, remember that means outside, intra means within. So the ligaments that are on the outside of your knee, we have our medial collateral and our lateral collateral. And you also have two ligaments that sit on the inside of the knee. They're intracapsular. So those are going to be the anterior and posterior cruciate ligaments. We will talk more about these four as we move into the knee in the next video. Now the purpose of the ligaments are to help basically keep the articulating bones together so they don't, waver side to side or anterior to posterior. We have a very stable joint. There are people like myself who have lax ligaments, whose ligaments are a little bit stretchier than they should be. So their joints pop out or slip slightly out of position more often than they should. So when we have a joint completely go out of socket, that's called a dislocation. Talk more about that in the second video. If the two articulating bones of a joint, one kind of slips out, but it pops right back in, it doesn't fully come out and pop back in. It's just like a partial dislocation. We call that a subluxation. I have those very frequently. Now we also have, unfortunately, this is a tissue. Remember, ligaments are made of dense, regular connective tissue, where the collagen fibers are all running in the same direction. So we get a lot of tensile force in that direction. But if we apply a force opposite of those fibers, there's not a lot of tensile strength there, so they will tear. Okay, one of the most common tears that we have is an ACL tear of the knee. So right here's RG3, twisting motion, typically a twist and plant. That would lead to an ACL tear. You can have any sort of sideways force really can lead to those kinds of tears. So when we look on an MRI, this dark structure here, that's the ACL, completely intact. And when you look here, the yellow outline structure, you can see the complete tear. I encourage you all to watch this video. Once again, you can find the links on the PDFs. It's of a surgical repair of an ACL tear. So it's very, very interesting to watch. Now, one last note on ligament tears, especially those of you that had them know this. When you tear a ligament, their repair process and recuperation is a very long, arduous process compared to breaking a bone. Remember, dense, regular connective tissue is one of the few caveats we had to connective tissue in regards to high numbers of vasculature. So because there's such little vasculature and blood flow to ligaments, it takes them a lot longer to heal. That's why ligament repairs take a long time. Now, some other structures we can see, once again we're using the knee here, are menisci. Menisci are actually pieces of fibrocartilage, type of symphysis, and they are C-shaped pieces that help divide the joint. We have some in our jaw, but the major ones when people think of menisci are in the knee. Now, when we get to the knee, once again, we'll talk a little bit more about the medial and lateral meniscus, why they're important, and some clinical connections to them as well. Just so you can orient yourself, we are looking at the tibia, okay, from above, so the femur has been removed, and you can see the lateral and medial meniscus here. So just kind of help compartmentalize the joint. Now, in regards to clinical connection, I am going to talk about it more again in the next video, more pertaining to myself. But in general, meniscal tears are also another injury that can occur with synovial joints, another very common knee injury. The meniscus does not get a lot of blood supply. It does on its outer edges because it's sort of on the outside edge of the joint, and we call that the red zone. The inner portion does not get blood supply, and that's called the white zone. And in between is the red-white zone. Now, in regards to treatment, if you tear in the red zone, it's an easy repair because there is enough blood supply that it could allow that meniscus to heal. However, a lot of injuries are here in the red-white or white-white zone. And that really does not bode well for repair. Typically what's going to happen if you have a meniscal tear and you have to have surgery is they are just going to remove that portion, okay? So for those of you that are interested, this video right here goes through that process of removing and repairing a damaged meniscus. And we can talk more about my personal journey with that in the next video. Now there's another structure we can see in some synovial joints, particularly in the shoulder and in the hip, and these are called labrums. Labrums are little ridges, edges of fibrocartilage that help deepen the socket of the joint. Now, in the shoulder, that's really important, as we'll see in the next video. Your shoulder, that glenohumeral joint, the glenoid cavity, as you guys have seen in lab, is very, very almost flat. And the humeral head is quite round. That's great because it gives us so much movement with our upper limb. However, it also means that particular joint is more prone to dislocations. That's why we have our rotator cuff muscles and all these ligaments there. The labrum does help keep that joint in place. And we'll talk about in the next video about what happens if you tear that labrum. In the hip socket, as you guys have also seen, that is a very deep socket, right? The acetabulum, super deep, head of the femur fits right in there. Why would we need a labrum? You do not want a pelvic dislocation. We will talk about that in the next video, and it's quite horrendous to see, but we want the labrum in there just for extra protection because we want to have a super stable joint in the limb. Remember, the lower limb is not so much for range of motion as it is for locomotion and maintaining our posture. Now let's talk a little bit about the nerve and blood supply. I've kind of touched on it a little bit as we've talked today. There is blood, obviously, going to your synovial joints. If there was not, they would not have the ability to maintain any sort of livelihood. So they wouldn't be able to make energy, they wouldn't be fed, and they would basically die. Some areas we talked about with the meniscus, no vasculature. Other areas are a little bit higher. As you can see here, the outer surface of the joint has more vasculature than the inner portion. In terms of nerve supply, of course, there's nervous input here. Some of the nervous input we have, or input and output, tells the brain about pain, how bent or straight your joints are to help prevent things like hyperextension. And they're also utilized for just movement in general. So as we apply tension to the joint through our muscles, we have nerves that will send that information to the brain, letting us once again know how bent or how straight we are. We can utilize those muscles that are associated with that joint for things like reflexes as well. And we'll talk a little bit more about that area of sensation at the end of the semester. Now, the last couple structures we can see in synovial joints are bursae and tendon sheaths. Now, bursae are little fluid-filled sacs that we see in places like the shoulder and the elbow and the knee. They basically help protect and cushion body parts. So between your acromion and your clavicle, there's a little bursa there that's going to help. So as we perform different movements with our shoulder, we're not rubbing the bones against each other. When those bursae get inflamed for whatever reason, it becomes painful to move those joints, and that's what's called bursitis. Okay? Tendon sheaths are typically seen in the hands and in the feet because, as we'll see in our next unit, there are quite a few muscles that are going to start outside of those areas and insert into them. So there's a lot of tendons running through here that we need to keep protected. So they just kind of wrap around the tendon to help protect it from that excess friction. So here on the left, you can see the little bursa that's going to protect the acromion and clavicle from the humerus as we move it. And then here, you can see a dissected hand. And this S part that you see, this is the tendon sheath. All these A's and C's that you see, these are part of what are described as the tendon pulley system, which we don't get into in this course. Those of you that are heading on into physical therapy, you will learn about that, but these are just helping with producing different movements of the finger. But this is the tendon sheath. That's all I want to talk to you guys about for today, but I am going to leave you with this. Between now and the time you watch the next video, you need to run through all of the types of joint actions that a synovial joint can do. So that'll be the middle sort of portion of this lecture. The gliding joints, flexion, extension, abduction, adduction. You need to go through those and you need to understand them because we're going to be utilizing them not only in the next video talking about types of synovial joints, but they are going to be critical for your next lab exam when we start learning muscles, because the muscles are what are pulling on the joints, producing those actions. My recommendation to you is to have your notes or your phone with the Quizlet out, go outside and do the joint actions. If you just sit there and say them, you will not learn them well enough. Go outside, do adduction of the leg, do abduction of the arm. For those of you that work out, utilize that time for both working out and learning your joint functions. So between this video and the next video, make sure you've run through your synovial joint motions, both the angular as well as the special movements like opposition and inversion and eversion. And I'll see you guys in the next video.